So I used to believe that drug addicts were lesser people, and that they could get over their problem if they were just a little bit motivated. I felt that way because that's what my parents and teachers taught me as a kid. And society has since then reinforced that view. This mindset has led to individuals with addiction being the most stigmatized group in our culture. I would say the equivalent of modern-day lepers. Some people will say, just write them off. This is a tragedy, but it's one with a possible happier ending. As a practicing neonatologist here in Columbus, my goal has been to have healthy newborns. As concerned citizens, I think we all share the goal that in fact, all moms and babies should have the best possible future. Today, I want to talk to you about a program that reinforces the maternal-newborn bond. It promotes healthy families, and it helps women deal with their addiction issues. The illicit opiate problem, it continues to grow, and with it, more and more babies are exposed in utero to maternal opiate use. When I first came to Columbus a dozen years ago, I would see maybe just 3 or 4 babies a year who had been exposed to maternal opiates. And now I see about 200 per year. The Ohio Department of Health has reported that on average, there are 84 newborns withdrawing from maternal opiates in an Ohio hospital each day. Let's openly admit why it can be difficult to be non-judgmental when we think about a mom who abuses drugs. It can be heartbreaking to see a baby withdrawing from its mother's opiates. The baby can cry inconsolably for hours and have trouble getting any sleep. In this scenario, we tend to view the mom as a villain, as if she decided that her drug abuse was more important than the needs of her baby. But now we know that mom herself is the victim of a chronic neurological disease. And by adjusting our attitudes towards addiction, we can have improved outcomes for both moms and their babies. When I was in medical training, I was taught that drug addicts were highly manipulative drug seekers, and only a rigid rules approach could give them the guidance they needed to improve. We were told that we would look foolish to everyone if we tried to work cooperatively with them. But now we know that addiction is actually the expression of a disease process, and there are specific genes that have been identified in certain susceptible individuals that we know places them at higher risk of addiction. So let's be clear for a moment how most addicts get started. Typically, it begins with a physician's prescription for painkillers following a surgery or traumatic event. And when that susceptible individual runs out of pills, they discover that they're starting to go through withdrawal. And in order to continue to be able to function as a parent, a spouse, or an employee, they need to find alternative sources of opiates. And that typically, inevitably, leads to illicit drug-seeking behavior. The other group at particularly high risk are those who have undertreated mental health issues, especially when accompanied by highly stressful social situations. Blaming these individuals for their drug addiction is like blaming the person who has epilepsy or dwarfism. And compounding the problem, the stigma associated with addiction makes it very difficult for these people to seek out the treatment they need. Typically, when a woman becomes pregnant, she might decide to lead a healthier lifestyle. And I think we've all known people who have given up caffeine or cigarettes. And so my moms may try to give up illicit drugs. Unfortunately, we must discourage complete opiate abstinence in opiate addicts during pregnancy because it can be dangerous for the baby to withdraw inside of mom. So the preferred method is to replace mom's illicit opiates like heroin with prescribed methadone or Suboxone, which is an opiate replacement therapy that can remove much of the drug-seeking craving in the mom, allow her to have improved nutrition and better prenatal care. This medication, however, does not prevent the risk of withdrawal in the baby after birth. So when a woman delivers, the hospital is going to be using a scoring system to look for the presence and to assess the severity of the baby's withdrawal. And this scoring system looks at things like excessive crying or excessive sucking, spitting up after feeds or watery stools. But of course, these are symptoms that all babies can display to one degree or another. And so what we found is that this scoring system tends to create an adversarial relationship between the new mom and the healthcare team, which really prevents us from establishing good rapport and getting good parental teaching of safe newborn care. If the baby scores too high, then he's transferred to the neonatal intensive care unit, where he can be more closely monitored and receive medication to control his symptoms. The unfortunate consequence of NICU admission is that mom and baby are now physically separated, and we've interrupted that golden opportunity to establish a strong maternal-infant bond. Typical NICU stay for this disorder is going to be about 2 weeks. And imagine how long that 2 weeks must seem to the woman who has other children at home or who maybe has transportation challenges and finds it difficult to visit her baby while in the NICU. And imagine how frustrating it must be for her when this is the outcome after she did all the difficult things we asked her to do during the pregnancy, like giving up her addictive substance, attending to more frequent doctor visits, remembering to take a daily medication, and answering a lot of probing questions from judging professionals. Upon NICU discharge, about 80% of these babies will go home with their mom, but we've interrupted the maternal-newborn bond oftentimes, and for some, we've really ruined mom's confidence in her ability to take care of her baby comfortably. And unfortunately, with current traditional care, about half of the babies whose moms are in drug treatment need to go this NICU route. So in 2012, I was lucky enough to hear Dr. Ron Abraham speak about an amazing program he had at the First Center in Vancouver, Canada, for addicted moms and their babies. He used a care model called harm reduction, which recognized that if addiction is truly a chronic medical condition, then it's unrealistic to expect an immediate cure. One would not expect an immediate cure for diabetes or for hypertension, and so it's not fair in addiction either. But he discovered that if we could have gradual improvement in these moms on a continuous basis, and in the beginning, eliminate the most risky behaviors, then he could really make a huge impact and have improved outcomes. Being part of the Canadian province system, he had his funding through the province, and he was able to keep many of his moms in the hospital for as much as 2 weeks before and 2 weeks after delivery. And he had many more good outcomes than we were used to seeing here. So it seemed like we had the opportunity to improve what we did. And this inspired a group of us to get together to see whether we could create a program that provide comprehensive prenatal care and a family-centered approach after delivery right here in Columbus. We were fortunate to be given a mom's grant from the state of Ohio, and that allowed for the creation of the Mother-Infant Recovery Clinic. So this clinic was open 1/2 day per week. It provided prenatal care, medication-assisted therapy, and group counseling all in one setting. And there were also community peer mentors that were available to these moms for the rest of the week. We held a local all-day conference for nurses where we introduced the concept of addiction as a chronic medical disease, and we gave them instruction on how they can be supportive to mom in being able to soothe her own baby, utilizing techniques like skin-to-skin care and breastfeeding. As much as possible, we tried to have all the baby's care brought to mom's room, avoiding the loud and brightly lit well-baby nursery. And we tried to provide the baby's care on the baby schedule rather than the hospital schedule. The results of this pilot project were really startling. We found that 90% of these 38 moms and babies in this pilot project, 90% were able to go home directly from the postpartum floor after just 3 to 5 days of observation. And whereas typically we were sending half of these babies to the NICU, we only sent 4 of them to the NICU. And in most of those cases, those were moms who were physically too ill after delivery to be able to take care of their babies. When we followed these infants after discharge, none of them required inpatient or outpatient management for withdrawal symptoms. So I think there's some real significant advantages to what we found in this program. First, the moms were confident in their ability to care for their babies, and they had learned soothing techniques that they can then use at home when the baby became irritable. We didn't interrupt that period of maternal newborn bonding, which should lessen our risk about the potential for child abuse and neglect. By avoiding prolonged and costly NICU care, there were huge financial savings. And lastly, women who were able to successfully transition to motherhood now had the additional self-confidence that they could go on and continue to address their own addiction disease. So we know that the greatest predictor of long-term successful child development is being present in a stable and loving family. While we continue to argue about the best way to address the opiate crisis, there's tens of thousands of women and their children caught in the crossfire. This project, with coordinated prenatal care and a family-centered approach after delivery, required no expensive equipment, and it should be easily scalable to other delivery facilities. But proper prioritization of funding is now needed to allow for that growth to occur. I think it's time for us to advance our attitudes about addiction to agree with the science and allow these women and children to have the brightest future possible. Thank you.